Well, good morning. Can everyone hear me? Good morning. So, needless to say, I'm excited about the opportunity to be with all of you today, but more importantly, to be able to bring to the forefront some of the work that Patient Advocate Foundation has been doing over the past year to really take our platform of services and supports to the community at the level where patients can most intersect with us more directly. So I want you to actually take a journey with me. So I'm going to ask everyone to just close their eyes for a moment. Do not fall asleep. Close your eyes and just listen to my voice. So let's just take a moment, be still, and close our eyes. Jonathan, 10-year-old kid, just woke up from a great night's sleep. Goes to his closet, pulls out some clothes, and he's getting ready to go outside. Jonathan goes downstairs. He opens the door. He walks out into his community. He's excited about being able to take a walk down to his favorite park where he can play with his friends on the swings. They can jump, they can run, they can laugh, they can play, they can be kids. And guess what? Jonathan's mother is really glad that he can go out and do it. So the two of them leave the house. As they're walking down the street, they're awe in the new community garden that their neighbors are just tilling. They're planting tomatoes, watermelons, cantaloupe, collard greens. As Jonathan and his mother take it all in, they continue to walk, and they see the neighborhood church, and they see Bishop Sunshine waving at everybody. They see the congregants out, laughing, playing, joying. They hear the songs coming through the windows as the choir rehearses for Sunday service. As they turn the corner, they see the construction team building a new grocery store in their community. Jonathan's mother is happy because now she can walk to the store and get fresh fruits and vegetables and everything that her family needs. Oh, and look, across from the grocery store, a new school so that Jonathan and his friends can learn in a safe, wonderful environment. As Jonathan and his mom continue to walk, they turn the corner and they see the health clinic is giving flu shots for children and their families at no cost at all. And while they're there, Jonathan's mother can get her blood pressure checked. They've reached their journey. Jonathan simply goes across to the park. His mother goes into the hair salon where she can get all duded up for the day because tomorrow she has a doctor's appointment and she wants to look her best. Jonathan and his mother on a journey through a special day. But wait, the alarm clock goes off and Jonathan wakes up and he realized it was all just a dream. Open your eyes. I brought you back to our reality, right? But why isn't Jonathan's dream a reality for every single community in our country? We realize for the populations that we're talking about, there's a Jonathan and his mother situation in every community in this country. And it's only further compounded. I think in the first panel they highlighted the fact that that was the experience for individuals with resources. But what about those who don't? There's not a safe sidewalk for Jonathan to walk to. We know with the current state of critical access hospitals closing that this reality of a 1 hour or 2 hour commute to a doctor's appointment may be a very real issue for Jonathan's mother. But guess what? She has to take the day off work without pay to be able to do that. And she also has to say, do I take this day off work to go to the doctor? Or do I take this day off to travel 45 minutes to get to the closest grocery store in my community? It's important for us to make sure we raise to the forefront the context in which health takes place. It is not just the healthcare system, but there's a societal context that has the potential to either impact or impede health. Today, I want to highlight for you PAF's approach to addressing some of these emerging issues. So, how many of us have built programs or we've heard the phrase, if we build it, they will come? How many of us have said that? How many of us thought that? How many of us have said, oh, there's a problem if I just build this program, if I build this community garden, if I do this kind of safety net transportation program, if I bring these human service organizations into the fold, that is all we need to do, and we've solved the problem. Any of us who've been in public health, we've all been guilty of that. I want to thank Amy for assessing the room earlier, because what it did is it shows us the very thing and the very approach that we have to take. It is truly the intersection of various sectors, whether it's social service, human service, the health system, faith-based organizations, advocacy group. That is the tapestry that is really needed for us to really help those populations that may be experiencing the high rates of disparities across this country. However, we tend to approach everything as a very siloed approach. Social service agencies only focus on those social service issues. Our health systems only focus on those health-related issues. Our faith-based organizations focus on your spirituality. But now is the time. Now is the time for us to stop running an individual 60-yard dash, but collectively come together in a relay and identify our rightful place, our rightful position, and the leg that each of us needs to run in this journey, in this relay race called health. PAF, as an organization, realized that although, when you think about the populations that we serve, 25% of the population that we as an organization serve have a household income of less than $11,000. 23% of the population that we as an organization serve has a household income between $12,000 and $23,000. 13% of the populations that we serve have a household income of $24,000 to $35,000. Collectively, we're talking about over 60% of the population that we as an organization serve across this country, as we are a national organization, has a household income of less than $34,000. Now, I don't know about you, but I don't think that leaves anyone really any room financially to get sick. And more importantly, it doesn't leave room for anyone that is suffering from a chronic condition. So we have to do things differently in order for us to experience different health outcomes and quality of life for some of our most vulnerable populations in this country. So for us as an organization, we said, we know this. We know that we are serving some of the most indigent, limited resource, most vulnerable populations, but is that intentional for us, or is that by coincidence? How do people come to know who we are? How do people begin to learn and tap into, become connected to the resources that we provide? We can't let this be those who know, or those who know, or those who are in the know, or those who get connected, or those who know someone, who knows someone, who knows someone, they get connected. We had to be intentional and deliberate in our approach to make sure that those populations across this country that are most vulnerable have a direct pipeline to connect with us. And guess what we realized? That meant we may not be the right people to make these things happen. Why was this important? I am sure many of you have seen this slide, and I want to draw your attention to the two images, right? So one talks about equality. Everybody starts from the same place. The other one talks about equity, which is really about fairness, right? So we like baseball. I like baseball. I'm a baseball mom, I confess. And when my son is now 17, about 6'4". He's always loved baseball. But if he was in this image at the age of 2 months, if we were standing behind this fence, he would not have been able to see the sports that he loved, right? Well, now that he's 6'4", he can see over the fence, climb on it, and probably stand on the fence. But I raise that because we have to understand that I think Bob said it beautifully, there is no cookie cutter approach that we're gonna have to take, right? Everybody has access to the field. The field is available to everyone, but everyone can't see the same images of what's going on over that fence. And so what do we need to do differently to ensure that everyone at least has the same degree of access, Remember, we talk about availability and access as if they are the same thing. They are mutually exclusive. We know that there are healthcare systems that exist in every single community in our country. We know that, right? We know that they're available, but we also know there's still 16% of people that were served by PAF that were still uninsured. So it's available, but they don't have access. We're talking about palliative care, and I think Diane raised a point about, yes, it's available, but still everyone does not have access. So it's almost a crime as if we have these invaluable resources and tools that can enhance the quality of person's lives, and we kind of dangle it and say, yeah, it's something going on great on the other side of the fence, but I know you can't see it, but it would be good for you. So what do we have to do differently so that everyone has an opportunity to participate in the game? Not hear about it on the news, not read about it in the headline, but be an active participant in their own health. And so that is why I bring this image forward, because I think what it does is it really forces us to understand that in some communities, it is going to take us knocking on doors, working with our social service, human service, and some of the Meals on Wheels and other types of programs to identify what are those other social constraints that patients are experiencing. You can't talk to a patient about their health care if their tummy is hungry. You can't talk to a patient about their health care if they are worrying about how they're going to keep the lights on. So we realize that there may be different approaches for different communities that we actually have to take. And guess what? Not only for different communities geographically, from a racial and ethnic perspective, we have to be culturally competent. We have to understand the context in which people live their lives, whether it's their spiritual beliefs, whether it's an ethnic cultural belief. No matter what it is, we have to do our homework to do that proper initial assessment. We have to ask, then we tell, then we ask again. We ask them, just like we want to ask patients how they like to receive information, we have to ask them, what is important to you in the context of your health and your community in which you thrive? And from that, then we take the message that we want to communicate to them, and we tailor it in a way that is reflective of what's important to them and move it forward. I've started the alarm. That is a confirmation that this is a call to action, and let's do it right now. We have fired the alarm. All right. I guarantee you there's no other workshop that can say that had this type of experience, right? So with that, just to kind of bring us back, again, I just want to refocus us a little bit, that it's going to be critically important that as we look at those populations with chronic and serious illness, that we also be mindful of the impact of those illnesses on the caregiver as well. I am a caregiver. My mother has progressive multiple sclerosis, and I have been her caregiver now for the past 22 years. And it has been an experience. It has been one where I don't fully understand what she's experiencing, but because she is mother feels like I should be living my life and not having to have her at the forefront of my life. But I think the question was raised. I think Gwen made the comment earlier about it is so important for those of us who are in that caregiver space, invite us in order to provide that care, but also let's be very mindful to invite those caregivers in to make sure that they have the supports that they need, whether they are the emotional support, the social support, the financial support, because the chronic illness becomes an impact on the entire family. It threatens the very financial stability of the entire family. And that does that for those individuals who have means. You know, I highlighted for all of you the greatest percentage of the population that we as an organization serve, but we also serve those individuals who some will say were pretty well-to-do, may have incomes that are a little bit higher than those numbers that I provided, but guess what? They still have need. And once there's a chronic condition comes into play, everything gets turned upside down. It just becomes more financially toxic for those populations that are already very limited in their resources, those populations that already are experiencing disparities across a whole variety of things. But I don't want to lose sight of the importance of us us remembering to bring into the caregiver piece. And that's also important from a social and a cultural context as well, where the role of that family and that caregiver is number one. And so even as we think about our strategies, as we think about our outreach or engagement to these populations, we also want to be sensitive to engage them in these kind of conversations. And with that, that becomes a part of our equity conversation. You know, it is no longer just solely focusing on that patient, but what are all those surrounding pieces that you need to bring to play and help orchestrate this, right? Because guess what? Healthcare is complex. It's like a plate of spaghetti. I always say it's like Prego. It's in there. You know, so everything that you need is in there. You know, every ingredient you need. But guess what? When you open up a jar of Prego, you can't pull out the tomato sauce. You can't pull out the onion powder and all those things. You just know that it's in there. And healthcare is the same way. But for our vulnerable populations, they can't unpack that. Because they can't unpack that, because of all these other things like low literacy rates, lack of or no literacy, let's be very clear. For those populations where English is not their primary language, when you add healthcare in it sounds like the teacher in Charlie Brown. And so I think these are very real issues, and because of that, the way that we approach community engagement, the way that we help patients, their caregivers, really thrive and achieve this quality of life that we're talking about, we have to think differently about who's at the table. One of my colleagues always says that if you're not at the table, you're on the table. And so I think that as we think about our racial, geographic, and ethnically diverse populations, we have to create a table for them first. And let's not think that we have to build that table in the exclusion of them, but we have to build that table with the inclusion of them. And once we build a table, we have to invite them to it, right? Why come into my community, tell me everything I need, but you don't invite me to tell you how I want to receive what I need? So that's the different approach that we have to take in terms of how we do our programming. So why was this important to PAF? And you know, for us it becomes, here we are, this national organization with this phenomenal platform of providing case management support to individuals with chronic, life-threatening, and debilitating conditions across this country, right? But when we look at mortality data, and we started this, I started looking at our breast cancer mortality data and begin to look at what are those top 10 geographies where the breast cancer mortality between African American and Caucasian women was 50% and greater. This is actually coming from the Avon Breast Cancer Crusade study. And there were 10 cities. Memphis was number one, right? So I started saying, all right, let me dig in this a little deep. So looked at what does our patient service data look like from these areas? Because it's to ask the question of, why are these premature deaths happening? Is it all because people don't have access to early screening and detection? Possibly, that may be a contributing factor. Or are they happening because there are some other social needs, other social and logistical needs that these patients have that no one is there to help them connect to or navigate? That may be where we fit. So we started this to say, how do we take our platform and services and expand it very intentionally to those geographies where we know are experiencing very high premature mortalities for a couple of conditions, starting with breast cancer, of course, and creating these direct pipelines from those communities to our platforms of services and supports. Let us use this as a leveraging point to understand the data at the community level, right? Because how many of us have been on a plane? Y'all been on a plane, don't play. When you're looking out at 30,000 feet, all the houses look the same, right? They all look beautiful. They look like trees. You see trees and houses for days. When you get down to the 10 feet level, it looks very different. You learn that those weren't houses. Those are abandoned buildings. You don't see the homeless people on the curb. You don't see that mother that is up all night pacing the floor because she has an eviction notice, a cutoff notice, and guess what? She just found out 3 weeks ago that she has a stage 2B cancer, and she has 3 children, and all she can do is open the door and peep in their room, and she's worried about that. But you don't see that at that 30,000 feet level. You see that at the 10-foot level. And so as a result of that, we as an organization said, all right, we can no longer operate from this 30,000 feet. We have to go very intentionally into the communities, understand who those stakeholders are, understand what's the phenomenal work that's already going on at the community level, and ask, where is the appropriate seat at the table for us? What is it that you are not able to do that maybe us bringing our resources to bear alongside you helps you complete this race? And that is actually what we've done. And what we're doing with that is, as we learn more about these very, very limited resource communities, we can now take that, share it with our colleagues on the NPAF side, the National Patient Advocate Foundation side, and that gives them the leverage, that gives them the tools, the real data that they can go in at local level, at the state level, and even at the federal level to say, this isn't just happenstance. These are the 75 people from Memphis. These are the 200 women from Indianapolis. These are the 2,500 African American women from across the country who are experiencing these top 3 barriers to their health care. And you know what they are? Mostly transportation, inability to access screening because of the hours of operation of many screening facilities, and they can't take off work to go and do it. And thirdly, of course, health insurance. All of those things pretty much take place outside of the healthcare system, but they are a part of the social context in which individuals across our country are making their healthcare decisions every single day. So what do we do with that? We go into the community with our building blocks, right? And understand that it may be one where we need to bring together all of the human service organizations and the social service organizations and say, hey, what have we brought? Screenings on site when women are coming in to renew their WIC vouchers or food stamps or things of that nature. Or working with those local employers and say, you know, a healthy workforce is good for your bottom line. How can we work together so that your women and men in your facility don't have to take a day off work to get these screenings? How do we work together so that you can provide those screenings to them on site? It's helpful for you as the employer, but more importantly, you're providing an invaluable resource to your employees. And how do we begin to truly understand that there is a role for our faith-based institutions in all of this? And let's be cautious, because a couple of years ago, we made this major shift. Everybody wanted to work faith-based organization. Churches have been around forever. But all of a sudden, people saw them as a jewel, a resource, a connectiveness. But guess what? They don't have the same relevance in communities now that they always have. So we can't just rely on, oh, we're going to do it this way, just this way, that way. We have to be nimble enough to modify our strategies in a way that they're meaningful. Because at the end of the day, people will walk around with need and hurt, and you will never know. But there is somebody in that community that they will tell. So it's important to identify who those individuals are and make sure that they know how to connect the patients to you, your organizations, and what you do. It's not about us as an organization. It is about, do we have a service or resource that can help close the gap to help minimize many of the barriers that individuals, their caregivers, and even their providers are experiencing when they're trying to provide care. Understanding what's going on, taking that, formulating that into an active strategy with engagement of those who are on the ground. Because we're not in every single community, but there are people that are. And although I think we are a phenomenal organization, guess what? Everybody, I don't care how much I talk about our case management platform, our co-pay assistance program, our financial aid funds, there are still individuals across this country that will not reach out to us. But they may call Diane. So it's important to make sure Diane knows about it. They may call a Meals on Wheels program. And as that person is delivering that meal, they understand there are some other barriers that that patient may be encountering. So it's important for us to come out of our silos, because our silos do nothing but breed disparities. Our silos do nothing but breed inequities. And if we realize the true value of our collective impact, only then will we truly begin to see the disparities in our country subside.